Good afternoon, everybody. My name is Harm Sherbier. Welcome to the webinar. Today's topic is connecting Pennsylvania seniors with social services benefits. We have a large number of attendees. Welcome, everybody. It's great to see so many people on the call. I'm Harm Sherbier. I'll be your moderator today. Before we get started, today's presentation and webinar will be recorded. And so for future use, and we'll post on our website. If you do not want to be recorded, please disconnect right now. It says it also there. Session's being recorded. Fatima, let's go to the next slide. We have a very packed agenda. Welcome. The benefits of healthcare and social service benefits in Philadelphia and Pennsylvania. Introduction to the PACE program, PACE outreach, milestones, benefits data trust, BDT, and the Pew Challenge grant opportunities, and a PA RISE update. You will be learning a lot of acronyms and names, which I think is very, very good. These are all very important programs, and becoming familiar with what these acronyms mean and what these programs will do for our organizations and for our members is really, really important. So I'm hoping you bear with us and learn about what these programs mean. Fatima, next slide, please. I'll be your moderator. The panel today, the speakers will be Jessica Gillespie, who's the Senior Officer at the Pew Charitable Trust, Tom Snedden, the Director of the PACE program at the Pennsylvania Department of Aging, Bill Morella, the Vice President of Value-Based Care and Data Analytics at Health Share Exchange, Morgan Deerling, the Pennsylvania Engagement Manager, and Julian G., the Senior Innovation Manager, both at the Benefits Data Trust. A fantastic group of speakers. We'll learn a lot from them. So also, next slide, please. The reason for having the webinar today is also important. This is urgent. In 2 months, January 11th, 2023, the COVID public health emergency is scheduled to expire. And while that is, of course, from a COVID perspective, probably good news, because the pandemic doesn't seem as active anymore, from a benefits perspective, that has a lot of implications, and that will be the topic for today. What changes when those when the public health emergency expires, and what impact does it have on Medicaid recipients and other benefits recipients in Pennsylvania? With that, I would like to, next slide, please, hand over to our first presenter, Jessica Gillespie at the Pew Charitable Trust. Jessica.
Great. Thank you, Harm. Afternoon, everyone. Jessica Gillespie, Senior Officer with the Pew Fund for Health and Human Services. The Pew Fund is the grant-making arm of the Pew Charitable Trusts. We invest in direct service organizations in the greater Philadelphia area, so Philly and the 4 surrounding counties. And I'm excited to be here to talk with you about what we are learning from a macro and a micro perspective about benefits access, and specifically benefits access as it relates to healthcare. Next slide, please. So at the Pew Fund, we are by no means benefits access experts. Harm mentioned the looming challenge of the end of the public health emergency and its implication for the healthcare system. But we are also hearing about the implication of the end of the PHE from various parts of the benefits ecosystem. So for example, in the tax and income space, folks are really thinking about the loss of the child tax credit, which has been touted for lifting 16,000 of Pennsylvania's children out of poverty during the first year of the pandemic. So across these kind of basic needs, issue areas, think food, think housing, we're hearing about the loss of benefit supports and, really hearing about the loss of resources to support benefits as a result of the end of the PHE. So of course, these calls have focused our attention, but as we take a closer look at the benefit sectors, and I'm using the term benefit sectors, the plural purposely, benefits are most often structured in the context of specific needs. So the benefits ecosystem is complex and dynamic. So as we've looked at these systems, we've also noted other factors that really make a compelling case for prioritizing the issue of benefits access and uptake as a means of driving the well-being of Philadelphians. So I'll get to the slide now. Here are 4 points to reflect that rationale. We know that Philadelphia has the highest rate of deep poverty of any big city in the country. Now consider that fact in light of the reality that $450 million in Medicaid, EITC, and SNAP dollars go unspent by Philadelphians each year. There is a critical need here, but there's also a high leverage opportunity. Individuals and families can't thrive if their basic needs aren't being met. But we have evidence that some benefits work directly to lift people out of poverty, and all benefits serve as an important foundation for economic and social mobility. Finally, people power. There is a vibrant and committed group of providers and systems leaders who are poised to continue to build and strengthen systems of benefits related supports, many of which are on this call today, I'm sure. And we know that people power is critical when it comes to bringing about change. So next slide, please. I mentioned that we are not experts, but I like to think that we're experts at learning from experts. So to better understand the benefits access landscape, we brought together individuals from the city, intermediaries, and direct service organizations to discuss and identify promising approaches for improving benefits access and uptake. What I'll share with you today is an outcome of this conversation. I also want to mention that, benefits is a dynamic set of systems, and so we spent much of our time focused in these small groups on issue areas, so food, income and housing, food, income and tax, housing and utilities, and healthcare. Next slide, please. So I did mention that you can't talk about benefits in a singular way. There are many different benefit sectors, but I want to emphasize a point that came up time and again during the convening across the 4 issue areas that I mentioned. You can talk about systems and structures and data, and these are key points of focus when we talk about strengthening systems of support, but the work and the systems efforts have to be grounded in a commitment to supporting people who are often in very vulnerable situations. People first really could have been a mantra for the day, and I want us to be grounded in that same orientation as we move through this conversation over the next hour or so. I have a couple of stories here to help us do that. One that reflects the success of the system, another that demonstrates that there's still opportunity for growth. So first, Mindy. Mindy has been on Medicaid for the entire pandemic and recently reached out to the Pennsylvania Health Access Network to help with her renewal. FAN for short. She had been having issues getting her mail because she moved and was unsure of how to update her information online. FAN helped her submit her renewal, so she benefited from the support of a navigator, but she also benefited from the continuous enrollment requirement. So throughout the pandemic, she made too much to technically qualify for Medicaid, but was able to remain enrolled. She's making less money now, and so therefore qualifies based on income again. But if she hadn't been able to update her info, she would have been at risk of losing her Medicaid during the unwinding period. Next, Kian. Kian was a teenage mother. She received health coverage through Commonwealth for herself and her young son. She was also enrolled in SNAP through the support of a legal services attorney. And her medical coverage allowed her to get care from CHOP for a kidney condition that really required her to take daily medication and make frequent office visits. After she turned 19, she graduated high school, moved, got a new job, but she lost her health care benefits and has not figured out how to apply for other publicly subsidized coverage. So as a result, she's stopped taking her daily medication and is showing early signs of kidney failure at the age of 24. So a success, but also opportunity. Next, I've been talking for a couple of minutes, and so just wanted to provide a moment of interaction. I'd love to give a sense. Next slide, please, Fatima. I'd love to get a sense of where we are in this room in terms of our relationship to the issue of benefits access and uptake. So I just want to take 15 seconds to take a quick poll. Do you know someone who is struggling to access or sustain medical benefits? You can see you have 4 options here, and Fatima, we can launch the poll and provide the audience the opportunity to respond. Just do 15, 20 seconds.
Are you all seeing the poll?
I think so.
I saw it earlier, but then it went away.
Yeah, Fatima, I'm going to relaunch it right now.
Okay.
Thanks, Fatima.
Then please give us 1 second to relaunch the poll.
I think we're all continuing to gain facility with this technology. It's an opportunity and a challenge. And what we could also do is, if we can't launch the poll, please feel free. You see the response choices are lettered. So A, B, C, D, would love for folks to just, drop your response into the chat if you feel comfortable with that.
Here's the
There we
poll.
go. There it
It's on your
is.
screen now. So please, everybody, select all that apply in your situation.
All right, I think that's about 15 seconds. Fatima, did we get a good response?
Yes, we did.
Hey, can we see the results? All right, so, definite connection to the issue. And for those who don't know anyone, hopefully those stories were kind of a good grounding in the human aspect of this conversation. All right, let's move on to my final slide. Let's talk about learnings from the convening. Next slide, please.
Yeah, Fatima, can you go forward one more?
One more. Okay.
Oh.
I'm seeing the next slide. You guys can see it. Hold on one second.
Jessica, your next slide is about the key insights. Maybe you can start speaking to the slide while Fatima brings it up.
Sure. And so there were, in terms of learnings, there were 4 themes that held true across the conversation specific to the 4 benefit sectors. And we really interpreted those 4 themes as calls to action. So let me just do a little bit of finagling myself to pull up my slide. So the first was build upon the positive evolutions made during the pandemic. And I'm just going to read through those 4 themes and then talk about them in the context of the kind of the feedback or the insights from the healthcare specific group. So build upon the positive evolutions made during the pandemic. We know that the system was stressed, people needed more support, but we also know that, systems leaders and direct service providers were resilient to those needs and were able to kind of be responsive and make changes to address need. The second was increase Philadelphians' accessibility to benefits by reducing application burden. And so, the complexity of applications, the complexity of the renewal process, I guess in the case of healthcare, is something that was greatly discussed. Hold the systems, not individuals, accountable to ensuring access to and uptake of benefits. There we go. Thank you, Fatima. This is the idea that the system should come to the people. The people shouldn't necessarily have to come to the system. And then D is build a culture of collaborative leadership across city, government, and agencies. And so, collaboration to me is, and cooperation is the new innovation. So I'm going to talk about A and B. Thanks, Fatima, for pulling that up. A and B in the same breath. So the Medicaid continuous enrollment requirement was really touted as a significant and meaningful success. And this healthcare group was really concerned over the end of the public health emergency and the potential for coverage loss or interruption. So, thinking about how can you potentially use automatic enrollment as an opportunity to, kind of facilitate that lack of interruption, but also just a call for a system-wide push to spur action on the part of the system to educate recipients and to potentially, educate, the system itself so that it can be delivering accurate information and supports to end users of the system. So that's A and B. Fatima, can you click one more time? So in terms of holding the system, not individuals, accountable, this is the opportunity that I'm most excited about. How can we be more self-reflective of the ways in which we're putting up barriers? So data and auto enrollment were big conversations here. And so I know PACE is going to be something that's discussed in a little bit, but where is the opportunity to use existing data to, identify folks who are not in the system, or to facilitate continued access to those that already are in the system? And auto enrollment was a big part of that. And leveraging organizations like the Health Share Exchange to facilitate continuous access for those in the system was a point that was brought up. But also kind of where is the opportunity? And it seems like PACE is that opportunity for kind of these organizations or systems that hold data to kind of better cooperate, better share information, so that you're facilitating access not for those who are already in the system, but able to kind of better target and bring folks who aren't in the system, to the opportunity. And
Jessica,
yes.
in the interest of the other speakers, I would like you to
Cut it short.
Yes, please.
10 seconds away.
10 seconds.
So this final opportunity is to build a culture of collaborative leadership. And so, advocate, find a seat at the table. And I know this is going to be shared around. Sometimes it's hard to figure out, where is the table? And so have just provided a couple of different collaboratives that exist in the counties and also in Philadelphia here for your review in case you're looking to get activated and engaged.
Great.
Thanks,
Thank you, Jessica. Great place to start us all off. Next, I would like to ask Tom Sneddon to present his perspective. Before we do, attendees, if you have a question during any of these presentations, please type them in. I will be monitoring for questions, and we'll have some time at the end to address some of your questions. So please type them in, and I'll be keeping an eye on your questions list. Tom, Director of the PACE program at the Pennsylvania Department of Aging.
Thank you, Harmon. Good afternoon, everybody. Tell you a little bit about PACE and what we do. We're all about access and health equity in this program. PACE is a comprehensive drug benefit for older Pennsylvanians that offers low-cost medications to people that are qualified for the benefit. We're a state pharmacy assistance program that's federally qualified, meaning that we can contract with Part D plans to provide wraparound benefits, and we provide credible coverage, which means you don't have a penalty if you're late in applying for Part D for some reason. Next slide. Okay, so what do I mean by comprehensive coverage? Well, first dollar coverage, no deductibles, open formulary, nominal copays, and no dollar caps. You don't see that much anywhere. We also do a seamless wrap with Medicare Part D, and we have a very intensive and aggressive drug utilization review to protect our enrollment against drug misadventures. Next. Eligibility requirements, really simple: 65 years of age or older, PA resident for 90 consecutive days, got to meet income eligibility guidelines, and you cannot be a Medicaid enrollee. Next. So here are the income requirements for the program. I won't read those off. Suffice to say, these eligibility criteria qualify 75% of the 65 plus population in Pennsylvania, and we do not count assets, unlike Medicaid. Next. So as I mentioned, we have an open formulary, low copays. There are the copays. We don't do anything like co-insurance. These are pretty good copays today. And we do offer a 90-day supply. If the cardholder is in a D plan, 90% of our enrollment is in a D plan, and most of those people can get a 90-day supply. Next. So we operate with Part D very seamlessly for the enrollment. meaning that we cover the Part D deductible period, people in the donut hole, and we cover drugs that are not on a plan's formulary. Next. We also provide payments for the late enrollment penalty for individuals that didn't PACE if they happen to have one. We have take advantage of lower copays with some plans. A lot of plans have $0 copays for tier 1 generics, doing the 90-day supply, and this helps us greatly offset our program costs. Next. How do you go about applying? What multiple ways? You can call this 800 number, which takes you to our member service center and go online. You can mail us an application after you download it online, email it, fax it, or you can call our PACE Application Center, and Morgan will be talking about that here shortly. Next. Skipping over this pretty quickly, Morgan's going to be talking about this in some detail. We partner with various entities to help us do outreach and enrollment for eligibles. It's a great way to just pick up the phone, call this number, somebody will do the application for you. We don't really need much in the way of documents. When you give us permission to submit the application, you don't need a signature. Next. So in addition to providing support for applying and enrolling in PACE, we also do the same thing for the Medicare Low Income Subsidy or Extra Help, SNAP, LIHEAP, property tax, and rent rebate. Next. The program provides administrative support for other state agency programs, notably chronic renal disease program, which provides coverage to people who have end-stage renal disease. Next. Same thing for Health, Department of Health Special Pharmaceutical Benefit Program for people with HIV AIDS. We also do application assistance there. Next. And also the Department of Human Services Special Pharmaceutical Benefit Program that helps individuals with schizophrenia and pays for atypical antipsychotic meds. Next. Becky Laura is our manager for these activities, and this is her contact information. Next. PACE also has what we call the clearinghouse. So for people who, next slide, for people who are not eligible for PACE and need help with getting pharmacy coverage, health coverage, or lots of other things, we have a staff of people, team of people who are really good at getting people practically anything they need. Next slide. So this is the brochure for the clearinghouse activity. And as you can see there, we're doing prescription programs, food programs, housing assistance, employment, social and life services. Next slide. And this is how you go about connecting with us. Basically, call that 800 number there, and you'll get the help you need with practically anything. Next slide. And Judy, that's the qualifications. You need to be a PA resident, but you can be 18 years of age or older. We're going to help you. There's really no income criteria to do this. And then finally, Judy Dooley. Judy Dooley is the manager for this activity, and this is her contact information. That's it, Harm. I think
Thank you, Tom. That was a lot of information. And again, for the attendees, this session is being recorded. You can play back these slides, phone numbers, names, program specifics through HSX University, probably a day or two after we have this session. So HSX University is the search term, and you'll find this presentation and all these information. Tom, thank you. I'd like to hand it over to Bill Morella, Vice President of Value-Based Care and Analytics at Healthcare Exchange. Bill.
All right, thanks, Harm. Tim, you can go to the next slide, please. And just a quick word, if you want to download the handouts for this, that should be available as a PDF in the right-hand navigation menu. So you can have access to the contact information that Tom was showing. So I want to tell you a little bit about what HSX's role is in this partnership that we have with the Department of Aging and Benefits Data Trust. When the Department of Aging first contacted us about this, they basically said, HSX is the data hub for all this data moving around between payers and providers and everybody else that interacts with a patient. And they had this idea that shortly after someone's hospitalized, they just have a medical crisis. They may be getting a new diagnosis of a chronic illness that they're going to be living with the rest of their lives, maybe getting prescriptions for new maintenance drugs that they're going to be on the rest of their lives. And that might be an optimum time to reach out to people to see if they need help with either paying for their medications or with any of the other sorts of needs that Tom was showing on the brochure. So what HSX figured out how to do is basically shortly after someone leaves the hospital, whether it's an ED visit or whether they get admitted, and if they're 65 or older, so that they will, could qualify for PACE, and as long as they're a PA resident, those are the only two criteria we're using. We're sharing their information with Benefits Data Trust with the health system's permission, and we try not to do outreach to people who we know will not qualify. So we remove Medicaid enrollees, we remove duplicates, people who may have been on another list that BDT is using. And then BDT sends a letter on behalf of the health system shortly after discharge, ideally within about 2 weeks after the person gets home. We want them to receive this letter in the mail that looks like it's coming from the healthcare system. It's on the healthcare system's logo and letterhead. And they voluntarily decide to call into the PACE screening center. And that's where BDT screens for 19 different benefit programs simultaneously. So in the space of a 20-minute conversation, somebody could fill out all those applications and have BDT submitted on their behalf, which is a huge help to them, a huge help in terms of navigating all the benefits that they may be eligible for. And I can go to the next slide, Fatima. And this will just give you I'm not going to read all these, but I just want you to see sort of the categories of benefit programs that BDT is screening people for. Healthcare insurance and prescription, drug coverage, food and nutrition services, shelter costs, income support, and even childcare. And it's not unusual that they are even finding people who may be Medicare or Medicaid eligible and not yet enrolled. So they are also able to help connect people with those benefits as well. And go to the next slide. So we've sort of buried the lead here. This is probably the thing that caused us to organize this webinar in the first place. I'm very happy to tell you that we reached a significant milestone a month or two ago and crossed the $1 million threshold in terms of the value of the benefits for patients that we've been able to connect them with. And we have 4 health systems that are participating in this: Penn Medicine, Jefferson Health, Einstein Health, and Temple Health. And just from their populations alone, we've helped connect 738 households with over $1 million worth in benefits through October. And those, if they qualify now, they're likely to continue to qualify. So those are annual benefits, and we are still counting with the people that we're able to connect with. Go to the next slide, Fatima. So So the value there is basically the our estimate of what the value is to the patient of all those benefit programs. But there are also some benefits to payers and providers. So many of you who are on the phone. So in addition to getting, if someone enrolls in PACE, they're able to afford their medications. They're more likely to be adherent with any prescriptions they've had. We know that people are less likely to get hospitalized, less likely to get readmitted, and certainly lower costs for uncompensated care and shorter lengths of stay. So I couldn't find, I found a range of estimates for what the value is to a health system to avoid a readmission. It ranged from about $10,000 to about $50,000. So that's a pretty wide range, but I did find good estimates for several of these programs in terms of, how do they benefit the health systems and the payers who are bearing the risk for these patients. So PACE looked at a diabetes population and found that people who are non-adherent with their medications are twice as likely to be hospitalized and have longer lengths of stay and higher costs associated with that. SNAP in particular, from the Medicaid standpoint, saves $2,300 a year for every person you are able to enroll in Medicaid by virtue of fewer hospitalizations, fewer ED visits. LIHEAP, that's utility assistance. There is lower evidence of malnutrition for them and also lower odds of hospitalization. And nationally, charity care that the health systems provide every year dropped by about 23% after the Affordable Care Act went into implementation. And those declines were 4 times larger in Medicaid expansion states, of which Pennsylvania is obviously one. I bring that up because of the people that BDT is able to find who may be eligible for Medicare or Medicaid. The idea of getting somebody insurance obviously is going to benefit the payers and providers by not having care being uncompensated. We'll go to the next slide. So very quickly, I want to talk a little bit about an analytics project we did. We tried to see if we could do better at identifying who may be eligible for these benefit programs. So we looked at people who we did get enrolled and other people who did not respond to the solicitation to see, could we find things that would predict whether a patient was more likely to submit a PACE application. And what we looked at a bunch of different things, chronic illnesses, what type of hospital admission got them on the list in the first place, some patient demographic characteristics, and we even looked at income, thinking that we don't have income data on individuals, but just using the median income for their zip code, we thought that might be predictive that we would find people in lower income zip codes were more likely to apply, but that turned out not to be the case. And I think the finding there is, even in relatively affluent areas, you can still have people who are experiencing difficulty and could be helped by some of these programs. The only things that really were predictive were marital status, gender, and a cancer diagnosis. We also looked at diabetes, thinking that might be a good indicator, but that turned out not to be significant either. We were hoping that more of these would be useful predictors, that they would help us refine our operations a little bit, but I don't know if that's the case. But what it does do is it points to some opportunities for us to expand the program, and I'm going to turn it over to Morgan to cover that. And Fatima, we can skip forward to Morgan's slides.
Fantastic. Thank you, Bill.
So Morgan Sealing, he's the Pennsylvania Engagement Manager, and together with Dr. Julian G., Senior Innovation Manager at the Benefits Data Trust. Morgan, here.
Yeah, so thank you all for coming. I'm going to try to breeze through this as quick as I can, since I think our excellent partners have already covered a lot of it. But just to give you a broad scope of BDT, who are we? So Benefits Data Trust is a national nonprofit harnessing the power of data, technology, and policy to provide efficient and dignified access to assistance, improving people's health and financial security. It's just the old mission statement there. Fatima, I think if you could skip ahead a few slides, I think we're at the tail end of bills here still. Yeah, one more for me. There we go. And then one more again. Bam, and here we are. This is what I was just referring to. If you wouldn't mind skipping forward for me one more time. So our vision is we want to see a world that connects people to essential benefits and services while treating them with dignity and respect. And we want to see lower healthcare costs, more efficient government, and people who are healthy, economically mobile, and thriving. Next slide, please. So how do we do that? We use a multi-pronged person-centered approach. We use data-driven outreach to contact people for tech-enabled assistance with our custom software. And then we screen folks for 20 different benefits now, actually, with the addition of the senior food box, across multiple government agencies. This allows us to provide dignified service at scale while we use cross-sector data sharing and outcomes-focused research to advocate for policy and process change to streamline access. And we do that thanks to wonderful partners like those who spoke already across different sectors like philanthropy, government, CBOs, HIEs, and healthcare plans and providers. Next slide. So we operate 3 main contact centers, the PACE Application Center, Benephilly, and the PA Benefit Center. We, of course, offer the benefits of our original partner, PACE and PACENet, but we also include the senior food box and the property tax and rent rebate. And we also do a lot of work with the Medicare Low-Income Subsidy and Medicare Savings Program. And as you can imagine, with our long-standing partnership with the Department of Aging, we shine a lot of light on those particular benefits. But over the last 2 decades, we've branched out into plenty of age-agnostic benefits as well. So that includes the Supplemental Nutrition Assistance Program, the Low-Income Home Energy Assistance Program, Medicaid CHIP, the Child Care Subsidy, and the Homestead Exemption. And there's a slew of additional benefits we screen for and point the clients towards applying through the appropriate agency or channel, which includes SSI, SSDI, QHP, WIC, TANF, the Earned Income Tax Credit, and the Child Tax Credit. Next slide, please. So we overcome access barriers by specializing in comprehensive person-centered application assistance. We provide direct assistance to tens of thousands of individuals per year to help them apply for benefits. And our benefit outreach specialists, or BOS, screen members for eligibility and submit applications on the client's behalf, all in one phone call. Next slide, please. So the BOS simplify and streamline these complex application processes. We're informative about the benefits the clients are applying for, and most importantly, we humanize the process. Speaking as someone who started in BDT's contact center, I've never worked anywhere with a bigger focus on treating clients with empathy and dignity. Next slide, please. So BDT does not work just in Pennsylvania. We've begun doing work in other states all over the country, and I'm pretty proud of our national impact. We've screened 1.2 million households for benefits to date, securing more than $9 billion in benefits to families in need. We estimate the average household we apply to receive $2,465 in public benefits annually, and there's another 3 million people receiving streamlined benefit access due to policy changes we've helped push forward since 2019. Now, who doesn't love big numbers like that? But we are here today to talk about Philadelphia. Next slide, please. We help thousands of Philadelphians every year, and our hometown is easily our most served location, and not just due to the volume of calls we do here. We also provide access to a larger variety of benefits, including through supporting the Benephilly Centers, which are local community-based organization partners who provide in-person assistance, among other things. Between the Benephilly hotline and the centers, we include things like the homestead exemption, low-income water assistance program, and temporary assistance for needy families. But despite all that, there's a lot of money being left on the table. I believe Jessica already mentioned this number, so let's move to the next slide. And that brings us to what we're going to do about it. So the BDT has been awarded the Pew Charitable Trust Fund for Health and Human Services, their first ever growth grant. So it's a 5-year, $4 billion award, which will enable BDT to develop an expansion strategy to increase its reach and impact so more Philadelphians can put food on their tables, stay safely in their homes, and access healthcare for themselves and their children. So the Pew Fund supports service providers assisting individuals and families in Philadelphia area facing complex challenges, and its growth grants are designed to significantly expand the capacity of strong organizations to improve the circumstances of those in need through high-quality research, informed services, and programs. And we'd like to think we're one of those strong organizations. And our opportunity with the Pew Growth Grant is to double our impact in the Philadelphia region, going from generating 34,000 applications to 68,000 over the next several years. So this growth will likely have to come from a variety of sources to reach this ambitious goal, including improved internal efficiencies, new low-touch methods, new phone assistant projects, and more. And to do this, we're conducting numerous small-scale pilots to act as a proof of concept for our work. We want to try all of the above and see what works and what doesn't. Next slide, please. So one obvious way to do that is by expanding upon the excellent model PACE has built for us and now reaching to older HSX patients after discharge and trying with adults under 65. Targeting those adults means we can't utilize PACE itself, which is of course our longest standing benefit, but there are a lot of benefits we can still help with. So that includes things which are universally applicable like SNAP, benefits that are mutually exclusive with PACE like Medicaid, and benefits that just aren't commonly used among older adults like CHIP and the Child Care Work Subsidy. Now I mentioned these are small scale experiments, which means limited space to participate. We're looking to outreach to up to 5,000 people to generate a few hundred calls to our contact center. And if you're interested in having the adults you serve participate in this pilot to enroll in as many benefits as possible, please speak up soon. Not before the end of the presentation though. And if we only want 5,000 people, we obviously aren't looking to talk to every adult in Philly. So to narrow down who we'd like to focus on, I'm going to hand it over to my colleague, Julian.
All right, thank you, Morgan. So we can go to the next slide. Thanks, Fatima. As Morgan was alluding to, we are just scratching the surface of the iceberg in terms of the ways in which we can partner with HSX to reach out to the patients, members, clients who are being served by hospitals in the Philly area. And we want to build on that success with our PACE program. So the existing inclusion criteria, I think you heard from Bill already, which is older adults who are being discharged from an inpatient or ED encounter. And what we're proposing to do now is we would look at patients over the age of 18 with any one of the following criteria. So a Z59 code indicating social drivers of health needs. So that's the ICD-10 codes referring to things like food insecurity, housing insecurity. In the past couple of years, CMS has pushed for increased resolution, precision, and implementation of those codes. So that's one potential place we can look to identify people who are in need of benefits assistance. High ED utilization in the past year. I think most of you are not strangers to the fact that our healthcare system is broken, and for those who are most in need, the ED is a very common place to seek care as well as seek services for social needs. And so we're thinking that would be another good population to reach. And then some disease-specific criteria are also on the table as well, including type 2 diabetes with an elevated A1C. You can look up Seth Berkowitz and Hilary Seligman. They've got some good papers indicating the very clear evidence that links food insecurity to elevated HbA1c. And another thing is cancer diagnosis in the past year. So if you recall what Bill was talking about a few minutes ago about how cancer diagnosis seems to be linked to people applying PACE applications in the evaluation of our PACE projects, that is indicative of the trend that some of you may have heard of financial toxicity in cancer care, which is there's not only the medical toxicity relating to receiving cancer care, but there is also significant financial burden that comes with a cancer diagnosis. So those are the inclusion criteria that we're thinking about. And then we can go to the next slide. Thanks. So the next steps for this include identifying who'd like to participate. Certainly we'd love to continue working with the 4 systems in our PACE project, but if there are others who are here today who are interested, we would love to talk to you. Continue scoping out and fully defining what those inclusion criteria are that you saw on the last slide. Amending the data use agreements that will enable us from a governance perspective to be doing this work. And then after that, completing the data transfer process of like specifying how the file is going to look, how often it gets sent between all the parties. And lastly, developing and deploying new outreach materials that, like Morgan was saying, will focus on benefits such as SNAP or Medicaid or the childcare subsidy, things that are sort of tailored to the populations that we'd like to reach out to. So all of this kind of boils down to, if you're interested in participating and learning more about this experiment that we'd like to do soon, please reach out to Bill by November 18th. And the reason for that November 18th date is because it's scientifically proven that November 18th is my birthday. So please do it. But also we're sort of like, this is a small experiment in which we would like to learn things quickly and be able to get out the door and share the lessons with the rest of you. So we want to spend time being intentional in designing it, but we also want to move this along. So whoever is most interested, we would love to hear from you. And that's the end of my bit, so we can keep on moving.
All right, I think this is going to be the last slide, and while I'm doing this, I'll just put in another plug to everybody to feel free to raise your hand if you'd like to speak. We can unmute you, or if you have questions or comments, please put them in the chat. And
we have some good questions, and I will bring them up after you finish your slides.
Okay, perfect. So I wanted to give everybody a quick update on a related program that we're just getting started with called PA Rise. So many of you may know the state in Pennsylvania, Department of Human Services, tried to stand up a network for connecting people with social needs a couple of years ago, and they canceled that procurement for a variety of reasons. And the whole idea, I think, kind of laid dormant during COVID. But the state has gotten federal money tied to COVID relief earmarked for this purpose. And the idea here is that all the organizations that are doing care management, discharge planning from hospitals, any organization that is trying to connect people with the community-based organizations that address many of the social needs that we've been talking about, they want to do that in what they call a closed loop fashion, so that if I'm working in a hospital and I refer my patient for transportation services, food support, what have you, that I find out if they actually got those services, and is that need being met? From the state's perspective, they also want to have an idea from a holistic perspective what is the level of different needs throughout the state in different areas of the state, and how well are those needs being met, and what is the CBO capacity to meet those needs at the current time. So they're looking for this to sort of help monitor this or do surveillance on these needs as well. But just at the level of an individual who's interacting with a care provider or a case manager at an insurance company, this program would basically help them not only make these referrals and close those loops, but also be able to see whether the person they're dealing with is also getting services from somebody else, or what other needs have they been screened for that may be documented already that they could help get the person connected with. So our goal at HSX is to basically make data about STOH needs and the services being provided to address them as liquid as the clinical data is today. That's a pretty high bar, but it's one that several other states are engaged in a similar journey, and we're hoping to join them. So the status right now is that we just got our signed contracts back from DHS just about a week ago. We have been meeting regularly with the other HIEs that are participating in the program, and the next steps for us are to basically craft an RFP for a vendor for the statewide platform. That'll be a competitive procurement that'll play out over the next month or two, and I hope by the end of Q1 that we will have a vendor chosen. And certainly we'll be communicating more between now and then to keep everybody updated, but wanted to be able to give you that brief update today. And Harm, I think that's it. I think we're ready for questions.
So before we go to the questions, Bill, one more time. So when we pick a vendor, what does it mean to health providers in our region? once a referral platform for social services is selected? What do you think it means directly for our providers?
Well, I mean, you know, we could talk for an hour about that, but short version is many of the providers and health systems are already doing that work today, but they're all in their own silos. So they can't see SDOH assessments that are done by other organizations in the community for the same patients. And they're not able to see whether anyone else has referred the patient for the same service that they're trying to connect them with. So potentially they can save a lot of time, avoid doing unnecessary screenings of patients, asking them uncomfortable questions that people don't like answering and clinicians don't like asking, and to basically, you know, share that data with each other through HSX. That's the basic goal.
Excellent. Yeah, that's wonderful. Good. Let's go to questions to the audience. If you have more questions, please add them to the questions box here. We have a number of really good questions. So the first question, which is very much in line with the discussion today, is from Marianne Philippe. She says, recently started to have a beneficiary counselor at one of their FQHC sites. However, we've struggled with little uptake of these services. So that's one problem, little uptake. Patients are either already receiving benefits or they don't qualify often because of documentation status. Any advice how their team can better serve our community? Who do I direct that question to? Tom, maybe to start with?
Yeah, Harm, I think what we have to do is just accept the fact that, you know, there are going to be people that either have coverage or they don't qualify for coverage. But there are clearly a lot of people who don't have these benefits. When I look at Philadelphia and PACE and I see, you know, 20,000 Philadelphia residents in the program, that seems like a very low number to me, even though I recognize that the expansion of Medicaid in recent years has taken away a number of people that otherwise would have been in PACE. But I think, as you mentioned at the beginning, with everybody having to requalify now next year, we may find a lot of those people don't qualify, and they should be applied for PACE.
Good. Anybody else want to chime in here? Morgan, Julian?
I'll add a couple of things. My politician's answer is that it's even when someone gets screened and finds out they're not eligible for benefits, I would argue that that is delivering certainty to that person about their potential eligibility in that moment is that delivers utility to the patient so that they don't know that they should then go fill out a bunch of applications for something and waste their time on something. And the other thing is, I'm not 100% sure about the situation we're describing, but there's a lot of people who say, I tried applying in the past and I didn't make it on, and then they then carry forward the assumption that they are forever not eligible, which is not true because eligibility rules are constantly changing. So I guess I would just sort of put it in your toolkit just in case it's not already in there to say, like, if you tried before and it didn't work, let's have that conversation again because you may be eligible today and we would love to help you out with that, or Benefili would love to help you out with that. And then I think there's also a question of just like, there's a bigger question of how do we get healthcare providers and healthcare teams to actually do the programs that we're imposing upon them, we're trying to pilot with them. And I think I will acknowledge that that is a difficult thing. And I'm not sure if you're talking to somebody directly at BDC already, but I'd love to get in touch and we can see if we can troubleshoot a little. But also kind of acknowledge that there's just a significant difficulty in increasing uptake of SDOH programs in the healthcare delivery setting until it is 100% paid for and added to our delivery guidelines and just integrated into the culture of things. And it can be hard to address all the needs when you're in an FQHC and people have 10 things going on, and why are we adding an 11th thing? So I do recognize that's hard, but would love to kind of have that conversation and think about, is there anything we can do differently?
Morgan, anything to add there?
No, I'm gonna go with Julian's answer.
Good, good. Here's a very Jessica, before we go on, do you have a perspective on this? Either people have already.
No, I think Julian gave a wonderful response, and Tom too.
Good, good, good. Here's a very quick question, I think. Can people have PACE and not have a Part D plan? I think, Tom, you probably have the answer to that.
Yes. Yeah, 10% done.
Good.
You
So don't discourage those people, right?
I mean, we try hard to convince people to be enrolled in a D plan because it saves us a lot of money. But the reality is, if they don't want to, they can opt out. So,
Good. Here's a question from Bridget McGovern. We are an FQHC located in the Pottstown area, serving many people who are a transient population from Philadelphia. We participate with HSX, are able to participate in the Pew pilot, and can we refer our patients to the BTT program? So it sounds like she is basically doing what you're asking her to do, to apply as being part of the program. But in addition to that, Bill, do you have any suggestions for Bridget and her team?
Yeah, I think that's a great idea. And again, love to connect with you offline, and we can certainly follow up about that. I mean, if you're an FQHC, obviously you're not going to be sending us patients that have been hospitalized, but if we can narrow your population down to maybe people you've done SDOH screening on, and that they're having trouble financially paying for their medications, let's certainly get them on the list. That would be great.
Good.
I'd also like to note that you can absolutely also refer clients to BDT regardless of anything with the Pew experiment. And I think that it might be fruitful for us to connect with you as well, because transient populations are a difficult one for our data-driven outreach to reach for obvious reasons. So if you have insights, we would love to hear them.
Good.
I also just put in the chat the general sort of way to get in touch with Benephili. And to be clear about what's different about the Pew experiment with HSX is the idea behind that is we would be conducting proactive outreach to people based on clinical data proxies. So that's kind of in addition and above to the existing sort of pathway that anybody can use today to get to us.
Yeah, good. Excellent panel. I'm afraid we might not get to all of the questions. I want to thank you all. Before we finish, there's a handout here. So if you want to get a copy of all this great information, including the names, the phone numbers, the program specifics, please download the handout that is in your panel right there. You can also see this program again. It's been recorded on HSX University. You can point your friends to that. So if you have colleagues or friends who you think should benefit from the information, please send them there. I would very much like to thank our panel, Tom Sneddon, Bill Morella, Julian G, Jessica Gillespie, Morgan Veerling, and thank you all for participating and attending this session. Good afternoon, everybody.
thank you. Take care.
Thank
Bye-bye.
you. Bye-bye.
Bye-bye.
Harm, are you Dutch?
No.